Wendell Primus was actually born in Eldora, Iowa, which I looked up today. As of the 2010 census, it had a population of 2,732. So I don't want anybody to think that despite his long career in Washington, that Wendell is actually an inside the Beltway guy. However, he did go first work for Congress in 1975, so I don't know if one of that Iowa stuff is worn off yet. Wendell's had many jobs on the Hill, chief economist of Ways and Means. He did a stint at the Department of Health and Human Services in the Clinton administration and actually left in protest when President Clinton signed the welfare reform bill. He spent some time at the Center on Budget and Policy Priorities, but most recently and relevant to this discussion, he's the chief health advisor to Speaker Nancy Pelosi. He was there during the ACA, when the ACA was passed, making common cause with Rahm Emanuel, or sometimes arguing with Rahm Emanuel, which doesn't distinguish you from many other people in Washington. But he's particularly involved in this big question of what do we do about prescription drug crisis, which seems to be one that there is bipartisan agreement that there's a problem. So Wendell, I think it would be useful for us if we could start talking a little bit about the Louisiana thing, and then we can broaden it up. So has Louisiana shown us the way for something that A, other states can do, or B, as the National Academy suggested, the federal government should do for all states?
I think what Rebecca Gee and her team has done is truly exciting, and there's much to commend it, trying to get Hep C and that infectious disease under control. But it's one state, it's one drug company, and it took a lot of time of very talented people to get to where they're at. I think that same result could be achieved much more efficiently and effectively if the Secretary had that authority.
Secretary of Health and Human Services.
Yeah, the Secretary here in Washington, D.C. Because I think Renee was right. We're going to see a whole avalanche of new drugs on the market that are going to challenge state budgets, sickle cell maybe being one of them, where you have many people on the Medicaid program with that particular disease. The cure or the making it a chronic condition is going to be very expensive. That's a horrible disease. And so I think there may be some trade-off here where the drug company gets the assurance that every person on the Medicaid program that is in clinical need of the drug gets access to that drug. And then in return, there is a much deeper price discount than we get today, and then the implications for the budgets in Louisiana and Mississippi and elsewhere might be for those, again, a few drugs with, again, very high spending. You could think maybe a higher FMAP or something like that. So I think
FMAP is the federal share of Medicaid.
So that the federal government, again, on these very expensive drugs, where we've then guaranteed that everybody on the Medicaid program gets it. And that did not happen. That did not happen with Sovaldi, even though I could argue that is what the Medicaid law says today. States put up barriers because sometimes of budget constraints to that, and the states varied a lot in how much access the recipient population really had to Sovaldi. And I think we're going to see several more drugs like that come down the pike in the very near future.
So does the Secretary of Health and Human Services currently have the authority to do what you just suggested?
No. That is the problem. I think President Trump and his team really do want to lower drug prices, but they don't have the authority. I mean, it came up in the question just now. There is this prohibition in at least Medicare from negotiating, and even the authorities that the Secretary is using to do the quote-unquote Part B International Price Index thing is authority that was granted to him by the ACA, which they're trying to take away, ironically. in the Texas case that was just recently heard in Louisiana or New Orleans.
I don't think there's any irony left in this one. I'm sorry, Wendell. So at the beginning of the year, you were publicly expressed optimism that the Congress could reach some agreement with the Trump White House to do something on prescription drugs. Not everybody in the Democratic caucus appreciated that sentiment. So it's been several months. Do you think there's a chance of the House of Representatives passing a bill that President Trump would agree to?
Yes, I'm still very optimistic that that can happen. We've been working on this problem as a team, the committee staff and I and several outside experts. So we were almost ready to roll something out, and then we thought it better that given the August recess, and I remember August 2009, and I think pharma, if we don't arm our new members, particularly with the arguments that pharma is going to advance, that it was much better that we wait until September. We could
remind people what happened in August 2009.
August 2009, there was a rebellion against the ACA that had just been reported out of all three committees on the House. Now, I'm not saying that would happen again exactly like that, but there is no doubt in my mind that pharma will argue very hard against drug negotiation of the kind we're talking about. And I think by early September, it takes time to write the legislation well. It takes time for the Office of the Actuary and the Congressional Budget Office to score it. And I think we're much better off that when this proposal is rolled out, that we have a very good defense of it, that it's very clear to the public, and that we have outside validators and the people who do the scoring of this legislation, that they will have been given time to actually create the official scores.
And can you give us just the general principles or outlines of what you've been thinking about?
Yes, there is some information that's already been in the public sector, and I think it's not just removing the non-interference clause. It's making sure that the Secretary is given clear authority and a clear mandate to do negotiation. I think the next thing that's very important is that Secretary be given clear instructions. I think for drugs that have been on the market for a long period of time that are without competition, one should be able to push the price down where, again, all of the research and development costs have been recovered many times over, that you should be able to push the price down much closer, probably not all the way to the marginal cost. And the drug industry is very interesting here. The marginal cost of producing the drug is probably like 1, 2, 3% of the list price. The first drug, the first pill, if you will, may cost literally $2 billion, $2.8 billion. So you've got to recover that R&D. So I think the clear instructions are make sure that the drug companies get rewarded for innovation, for cures, but that for drugs where you've already recovered all the R&D, that price should be pushed well below international prices. And the drug companies can still make money if their marginal cost is, let's say, if you give them 30% of the list price, they still will make substantial monies on every drug that's... So we want a clear mandate to create innovation and cures, but where they've already recovered it, we want to have substantial price reductions. And then I think the other thing that's critical here is you've got to give the tools to the Secretary to do that. And by a tool, I don't think the American public will tolerate saying no. That if you don't sell the drug, if the drug company doesn't accept the price, there's no sale. I don't think that's going to fly here. By a tool, I think you can talk about what I'll call a non-compliance, a fee, you can call it a tax or some kind, related to sales. So that's the tool. And then I think the other thing you've got to be very concerned about is stopping gaming. And by that I mean the price that's developed out of this process. I fear that if you don't think about the gaming that pharma might engage with, so let's say you lower the price for the public beneficiaries, Medicare and Medicaid, I think they would raise prices on commercial. So I think one important aspect of this is to make sure that whatever the price is that comes out of this process applies to all payers. I think the federal government has the authority and the constitutional ability to do that. I think another thing is making sure that other drugs in a company's portfolio doesn't go up to compensate, so you could handle that maybe by inflation rebates, et cetera. So I think those things are all part of the process here. So you have a clear mandate, clear instructions, the tools, and the ability to stop gaming.
So you'll give the Secretary the authority to negotiate effectively prices on drugs, I want to get to which drugs in a minute, for Medicare and Medicaid, both. And then you will have provisions to make sure that the drug companies don't raise prices on those drugs to private insurers or on other drugs. So there'll be quite a bit of oversight and regulation there.
That is correct.
And is this going to apply to, you referred to drugs that have been on the market for a long time that don't have any competition. Is that the whole universe you're going to cover?
Yeah, I think, again, it's not going to be drugs, orphan drugs, for example. It's going to be not necessarily our most expensive, but where our aggregate expenditures are the highest. And just to give you an example, 25 drugs in the Part D program are 23% of net Part D spending. 250 drugs in Parts B and D out of about 8,000 or 9,000 drugs comprise 56% of Parts B and D drug spending. So again, there's a very small drugs without competition that are really burdening government expenditures significantly. And I think if you can lower those prices without hurting innovation, the country will be ahead, along with the requirement that those who are in clinical need of that drug actually get the drug.
And how do you make sure that happens?
Well, I explained a little bit on the Medicaid side. I mean,
right.
And then I think what we also want to engage in is, my expectation is that this will save the government substantial sums of money, and then the members can decide that they could take those savings, lower the out-of-pocket. There is right now no out-of-pocket limit in Part D, for example. And so we could establish an out-of-pocket limit in Part D, lower cost sharing, if you will, and bring that down enormously, so that our public beneficiaries would benefit twice, if you will. They get lower prices, plus they get a much better Part D program.
Okay, so let's talk a little bit about the politics. So first, is the left wing of the Democratic Party in the House comfortable with this?
Yes and no. I've talked to many of our progressives in the caucus. I think, again, when the details of this are known, when they see the scores, I'm very comfortable that they will accept it. I worry just as much about the moderates and the messages that we'll hear from pharma that says, oh, you're hurting innovation, you're going to stop cures, and all of that. So,
and what's your answer to that one, the innovation thing?
Well, I think we want, again, those clear instructions to the Secretary to make sure that innovation is rewarded, that they can recover their research and development cost, et cetera. And we may also, I mean, again, these are decisions the members will make. We could put some money into NCATS which is the institute at the National Institutes of Health that worries about investments in orphan drugs. I mean, there clearly are market failures here, not only in pricing, et cetera, but there's also some drugs for which the number of people in America with that disease, or even worldwide with that disease, causes drug companies not to do the right amount of investment in that particular disease just because the N is not big enough.
And what about the Senate?
Well, I've had some experience with that.
Some of it favorable, actually.
I mean, in 2015, I think the conventional wisdom in this town was we were not going to do an SGR fix. And in fact, I think if you asked any lobbyist,
the doctor
that was
fees.
the doctor fix, yes.
Doctor fees for Medicare.
Right.
There was.
And then Speaker Boehner and the Democratic leader, Nancy Pelosi, got together and said, we're going to do a deal. And I had the privilege of negotiating that with one of Boehner's key health persons. And it passed the House overwhelmingly 397 to something. And as a result of that mandate, when you get something out of the House with a very high vote, the Senate is somewhat forced to. And I think, again, this all depends on a lot of things that will happen. But again, I think if the Democrats unveil this and the administration says they like it, you could see this passing the House overwhelmingly, and then who knows what happens in the Senate.
Have you been talking to the Senate? Do they know what you're doing?
People have some idea.
Okay, and what about, are you comfortable that comfortable is not the right word. Do you expect the administration to support the plan that you have outlined here?
I know the press says that I've been negotiating with the administration. That is absolutely not true. We have kept the administration somewhat informed about what we're doing, et cetera. And my hope is, because I do truly believe that the staff of the Trump administration do want to cut prices. And the problem is, as I've told them many times, they do not have the authority. And without the authority and the tools, they cannot get there. And so I think it requires the Congress to act, and hopefully the Democrats can coalesce around this when it's rolled out in September, both our left and our moderates, and that the administration will see the wisdom of that and come on board and support it, and we'll see what happens.
Do you think this will get through Congress this calendar year?
I think if we really want to get it done, it behooves us to get it done before the election year.
Right.
And again, I think there can be some clear benefits from lowering drug prices and reinvesting them and making the Part D program substantially better off.
Wendell, what do you say to the Democrats who basically don't want to ever give President Trump a win on anything because they think it'll handicap them in the 2020 race? What's your response to that, which I'm sure you've heard at least once?
Well, one is that's above my pay grade, and the speaker, is very clear. The Democrats ran on this in 2018. She is very clear that this is a table issue.
Kitchen table issue.
Kitchen table, thank you. Kitchen table issue. She wants lower drug prices for the American public, and I've been educated under Tom Foley and Dan Rostenkowski and now Nancy Pelosi. I think if you see the opportunity for getting legislation done, you take advantage of that opportunity without compromising your principles. And we'll see if that opportunity exists. But I have no doubt that the person that I work for really wants to lower drug prices for the American people.
And interesting. Let me ask you about two other issues quickly before we go to the audience. So, as you mentioned, the Fifth Circuit is hearing this ACA case in which the question is, having lowered the penalty for not having insurance to zero, does that mean that it's no longer a tax? And does that mean it's unconstitutional? And does that mean the whole ACA is going to be thrown out by the courts? So what do you think is the state of play there, and what happens if the court rules against the ACA in that case?
Well, I think, one, it would be very unfortunate, and it would disrupt the lives of millions of Americans. Those with pre-existing conditions would have a lot to fear. The Medicaid expansions would be ruled unconstitutional, the age 26. There are so many things that would happen as a result of taking the penalty, which still does exist, but it goes down to zero, that this is just a very weak, extremely weak case. And conservative people, have written amicus briefs in this case saying they do not understand this. I think it will get, obviously, if the Fifth Circuit rules the wrong way, it will get appealed to the Supreme Court. I have confidence in the Chief Justice. He's ruled on this before, but we'll see. It would cause a lot of undue anguish. And the thing that when the Republicans took that penalty to zero, they made lots of statements on the Senate floor and elsewhere saying, we only take it to zero. We do not intend in any way, shape, or form that this should hurt people with pre-existing conditions. It's hard for me to believe that something that has been the law of the land since March of 2010 would now be ruled unconstitutional because the Congress took a penalty to zero when they did not intend that anything else in that law should change. It's just very hard for me to believe that an activist conservative court would do that to the American people.
And finally, you're in the midst of, not you, well, maybe you, I don't know, the speaker's in the midst of negotiations with the White House about a deal on the caps on annually appropriated spending and the debt ceiling. The press is that we're kind of getting closer, but we're not quite there yet. How close are we?
I was hoping I could even talk about it here, but we are not quite there. Yes, I think we're very close. The numbers have been agreed to. There's still one or two things holding it up, but I still have a lot of confidence we're going to get there by the end of the week.
End of the week?
Past the House.
Past the House.
Past the House by the end of the week, because they're going home for the August. The House is going home for the August recess. The Senate is still around for another week.
And 2 weeks? 2 years deal? Spending?
Yes. And a 2.5 year deal on the debt limit, and the sequesters are gone if everything works out appropriately.
Great. All right, we have time for some questions, and here's what I propose. I'm going to take maybe 3 questions, and then Wendell can pick and choose which ones he answers. Why don't we start with the gentleman here, and then we'll go to the woman over here. If you tell us, please, who you are and what your affiliation is.
Herb Rose, retired. A quickie question. Part of your approach is to make sure that innovation is rewarded by covering research and development of these drugs. How willing do you think Big Pharma is to revealing the costs that that is spent on research and development?
Thank you. Over here. Why don't you keep the mic in the back to the woman back there? Yeah, go ahead.
Hi there, my name is Rachel Kors. I'm a reporter with Inside Health Policy, and my understanding of kind of your structure is that there's some sort of backstop with arbitration to these negotiations. And my question is, what entity would kind of oversee that or play the arbiter role?
Thank you. And in the back?
Lauren Canary, National Viral Hepatitis Roundtable. I wonder if you could comment on whether or not you think that HHS or CMS should be doing more to penalize those state Medicaid programs that are continuing to place restrictions on treatment, to perhaps encourage them to follow Dr. Lee's position to eliminate hepatitis C.
Okay, so 3 questions, Wendell. 1, will the drug companies tell us what they spend on R&D so we know whether they're getting rewarded? 2, is there a backstop arbitration? And if so, who's the arbitrator? And third, should HHS or CMS do something to crack down on states that put limits on treatment, as we discussed?
I think we're still working on a little bit of, I think they're going to reluctantly give us information. I think that goes back giving the tool in terms of the what I'll call the non-compliance fee. And I think we want to give absolute assurances that when certain very confidential information is revealed, that it remains confidential. But I do think government has a right to know how much R&D has been spent, et cetera. So I think, again, this tool that I'm talking about, which you'll see unveiled, and they're going to do it very reluctantly, I have no doubt, but I think it's got to be part of the process of negotiation. In terms of the dispute resolution, I think it can be another government agency. You could think of the FTC, you could think of the Veterans Department that negotiates, et cetera. I don't think very many cases would actually go to arbitration. I mean, the idea would be to reach an agreement between the secretary and the drug manufacturer. And on that last case, I don't think I have enough information to give you a good answer, so we can maybe talk afterwards.
So the idea is that if the drug company refuses to come, you can't come to terms, that the government has a stick. I thought after the ACA you would call it a non-compliance tax, but okay, a non-compliance fee. There's probably some reason you're calling it a fee. That would be the stick. That either you do this or we're going to take some money.
And it's going to be sufficiently high so that the drug company, again, it's a non-compliance. We want the drug company to comply. We want the drug company to negotiate, et cetera. So,
okay, time for a couple more. There's a woman over here. Howen.
So you mentioned.
Tell us who you are.
Sorry, my name is Shauna Bram from Stein Mitchell LLP. You mentioned older drugs, and I'm taking that to mean maybe generics. And what I've seen is that when it comes to generics, the problem isn't necessarily pricing alone, but rather that generic companies exit the market when they see the price drop. So is there a mechanism to stop that from happening, given that we understand that the prices continue to increase or we see supply problems?
Thanks. Is there another one? Okay, you want to take that one, Wendell?
Yeah, so the older drugs I'm talking about here are still drugs without competition. I mean, Humira, as I understand it, has been on the market for quite a while. It has 120 patents plus. They still don't have competition, although some of that may be right. So we're not talking about drugs that have generics or biosimilars. We're talking here about single source, branded name drugs that have no generics. And that is where we're spending all the money. I mean, again, the statistic I gave you where 56% of spending in Part B and D are in just 250 drugs. So, I mean, you want to go negotiate where the money is. I mean, Willie Sutton robs banks because that's where the money is. So that's, I think, the class of drugs that where we, again, and it's the older drugs where I think we can get the biggest discount. I don't think necessarily for a new drug, a new launch, again, I'm not saying the launch prices are appropriate, but you do want the manufacturers to recover their R&D, et cetera. But it's those older drugs where we should be able to drive the price, the older single source drugs, where we should be able to drive the price down a long ways, because they've already recovered their R&D on those kind of drugs.
But they're going to make less money. There's going to be less incentive. There's no doubt about that. You're saying that the government will essentially say, you can recover your costs. We're going to continue new drugs. We're not going to. So we still have some really expensive new drugs coming on the market, and they won't be covered by this?
Yeah, that will be Pharma's argument. And, again, I think, they have an advantage relative to other technologies. One is they are sometimes building on the research, the public research that has gone on NIH, et cetera. Relative to, let's say, driverless cars, insurance reimburses 80-90% of the cost of the drug. So they are charging these high prices because they can.
Right.
And again, I think both Republicans and Democrats are saying those prices are too high. You can look at some drugs that was in a publication out of the Morning Consult I got this morning, where some drugs they've spent $90 billion over the sales, and they've made tons of money, and it's those drugs where we ought to be able to drive the prices down sufficiently. And I think again, I'm all for competition. I'm trained as an economist, but when the drug companies have taken advantage of their patent exclusivity, and that's what needs to be corrected here.
Great. Well, I want to thank Wendell and thank the whole panel and thank Rebecca Gee for doing something that allowed us to make history today, link the words Louisiana and innovation. I hope you will continue to innovate so we can do this again with something else. And I want to particularly thank Wendell for coming down here and doing this. Wendell's one of the people on the Hill who, let's just say that if we computed his wages at an hourly rate, Bernie Sanders would be upset that you're not making at least $15 an hour. So I don't think there's often enough credit given to the people like Wendell on both sides of the aisle who spend a lot of time working behind the scenes to make things better. So I particularly want to thank him, but also the USC-Brookings Schaeffer Center and my colleagues. So please join me in thanking everybody.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.